Ballard, who is the Chief Medical Officer for the Department of Health and Human Services. He's also a practicing family physician. And our second guest is Dr. Elizabeth Talbot, who is an infectious disease specialist, who is the Deputy State Epidemiologist and has been overseeing the allocation strategy for the state in terms of vaccine. Before we jump into formal presentation, I want to take a minute to introduce Denise, who is handling our closed captioning today, and who will just briefly describe, for those of you who would like to use the closed captioning features, how to access that. And so Denise, if you could spend a minute here just letting folks know. And I'm going to stop sharing my slide.
Thank you, Jonathan. Hello, everyone. My name is Denise. I'm your captioner for today's session. If you would like to utilize the closed captioning, you will see on the bottom of your screen on the toolbar, you have a CC button. Next to that button, there is a little arrow. If you click on that, it will give you an option to show subtitles or view full transcript. Either one works. The view full transcript will open a panel on the right side of your screen, and it's a run-in transcript. If you enable the captions and then you decide you would like to shut them off, same process. Click on the arrow, hide subtitles or the transcript, and you're good to go. My recommendation would be, if you don't need the captioning, don't turn them on, because there is a little bit of a delay, and it may be distracting, with that delay. But I think that's it, Jonathan. I think we're good.
Thank you, Denise.
Thank you.
I just want to say a quick thank you as well before we start to Deb Sheets from the Division of Long-Term Supports and Services, who has really helped us to coordinate today's presentation, and who has really taken the lead role within the division to help manage all COVID-related items within the Bureau of Developmental Services, and has been a really great partner to us in all of our efforts to make sure that people get testing, and now that we, with the vaccine rolling out, that we're working through the logistics of that. So Deb, thank you for all of your work.
Lunch next Friday. Thank you. And it is really terrific today to see so many families who are interested in learning more about the vaccine, the safety of the vaccine, and gaining some more confidence in their decision making to vaccinate. And it's terrific to see all of these people. I recognize a lot of names, and I want to thank everybody for taking the time.
Thank you, Deb. And just lastly, I want to let everybody know that we are recording today's session. It is not being live streamed, but we are recording it. It will be available as a link on our website and our YouTube channel, which we will send out through the area agencies in a social media post, so people will have access to it. So if you need to review some information a second time, that the content of today's presentation will be available early next week. So I think without any further ado, I really want to optimize our time with Drs. Talbot and Ballard, and I'll hand off to them.
Great, thank you so much. I'm very grateful for this opportunity to talk with you about vaccines, because ultimately I think that this is going to put us in a good place to turn this pandemic around. So I'm very happy for the large number of persons who are able to attend today. Jonathan, with a head nod, can you tell me that you're seeing my slide deck? Fantastic, thank you. So then I appreciate the time you've taken to type your questions as well. I've put some within the construct of this overview, and I tried to tell a coherent story, also anticipating questions, but this should be maybe about half of our time together, and then we'll go to questions directly. So first, some epi to let you know where we're at in our state, talk about the vaccine somewhat generically. I'd like to address an important issue, which is vaccine hesitancy, and then we'll talk about allocation. So what's going on? How do you keep track? Within our website, there's a dashboard, and this is a tremendous way to keep the local epidemiology in your awareness. This is the national circumstance on the Johns Hopkins, which I think you'll see immediately if you're not used to looking at these epidemic curves, that we've had 3 surges within the United States, and the third has been certainly the largest and has been sustained now. There is some suggestion that there's a flattening of that third surge, and we would love to see that happen. Quite analogously, New Hampshire has a current surge as well, and perhaps in this graphic you can see also that there may be some flattening of our current epidemic. I'd like to draw your attention to the fact that this steep fallout is simply a matter of receiving reports from patients and having patients seek healthcare and the like. So I think that this should not give you the message that, oh, we're done with this thing, but rather we are in this for the long haul, but there may be some recent turn of good events in our state. This is evidenced also by the fact that the number of people who are hospitalized, those with severe disease, needing oxygen, sometimes ventilators, has peaked and is steadily declining again, much to our collective relief. Yet there are deaths. I know that many of you participating also have had personal impact from this, whether loved ones ill or even succumbing. So pausing in a moment of empathy to say that this has been really a dreadful impact. It's not about the numbers, but the human suffering has been incalculable. In our current circumstances, you see that reflected mirroring the number of cases, the number of hospitalizations. We also are seeing people die of this disease. Well known to everyone is that the majority are associated with long-term care facilities because advanced age is a significant risk factor for such. However, note in the orange that there are also people in the community who are also succumbing to infection. So it's not only a phenomenon of being in a long-term care facility where risk is incurred for dying. So now perhaps the way that we may come to light at the end of our long, dark pandemic tunnel is through vaccination. So we are using really a mantra, a rejoining theme that we want safe, efficient, and equitable vaccination delivery to achieve immunity and break the back of this pandemic. If you're interested in what's going on globally and with other vaccines, there's a really great tool on the New York Times coronavirus vaccine tracker. And I've seen a few pre-positioned questions asking about some of the novel vaccine delivery systems, such as inhaled or oral. But right now, clearly, we are in the era of the messenger RNA vaccines in the United States. These are the Pfizer, BioNTech, and Moderna vaccines, with 3 vaccines that may come to us in the very soon weeks and months, such as the Johnson & Johnson vaccine, which would be a very welcome vaccine for the fact that it is 1 dose. We're watching Novavax, another novel vaccine strategy that can come to us through Operation Warp Speed funding. And then third probably is the AstraZeneca vaccine. So if you'd like to know more about the vaccine presentations that are coming yet, this is one resource that I find immensely accessible and wonderfully up to date. So my talking points around how these vaccines fit into control of this pandemic are that they are a new tool for prevention of COVID-19. They are not the end all be all. That is, we are not going to turn this epidemic, this pandemic around in days or weeks, but rather we need to sustain our efforts for community mitigation by avoiding travel, maintaining social distancing, avoiding group settings whenever possible, and universal mask wearing and scrupulous attention to hand hygiene. Vaccines are just one tool in the toolbox. So the 2 messenger RNA vaccines that have received US FDA emergency use authorization are the Pfizer-BioNTech, which I'll call Pfizer going forward, and the Moderna vaccines. These are 2 dose series. The Pfizer is given at least 21 days apart, and the Moderna at least 28 days apart. I'll preface statements in recognition of some questions that have come in, is that these vaccines have more similarities than differences. So both vaccines were tested in tens of thousands of adults that were enriched for persons who come from diverse backgrounds. That is, older adults, those with significant medical comorbidities, other illnesses that is, and those who come from communities of color, because we recognize that COVID-19 has disproportionately impacted those with racial and ethnic minorities. The clinical trial data are remarkably similar. They show both vaccines are safe and effective at a level of about 95%. That's absolutely remarkable. And I would frame this, that this greatly exceeds our expectations. Not but a few months ago, we were at best hoping for a vaccine that might be 50% or more efficacious, effective at what it does. And these have exceeded expectations across the board. There's a layman's phrase called herd immunity. Many of you understand in concept that the notion that if a lot of people have had a disease and have pre-existing then immunity, the virus can't jump from person to person any longer, but chains of transmission are broken because some people are no longer susceptible. So herd immunity refers to whether a person is no longer immune or a community is no longer immune because there's just been so much disease, but also because people get vaccinated. So in that context, I'd like to say that we have a very heavy lift ahead as a community, as a nation, as a planet, in order to bring the numbers high enough so that this virus can be broken in its chain of transmission. And that's probably 80 to 90% of our
I'll be right back.
So before talking about the vaccines and specifics, I'd like to, again, put it on the table, be very transparent that because of this heavy lift, we have to understand vaccine hesitancy. Part of why we're here today, joined together, is to try to overcome that. But it's intuitive in the words of it that it means people are reluctant or hesitating, refusing to take a vaccine even though available to them. So this is a top global health threat always when you think about measles, mumps, rubella, or other epidemic diseases, but especially now obvious for COVID-19. People are on a spectrum though. They are not one or the other. Most people accept all vaccines. Very few people refuse all. And in between are people on a spectrum where they are either accepting vaccines, but not with great confidence, accepting only some vaccines, waiting to see what happens with this COVID vaccine, or maybe just refusing this particular one. Some people refuse, but they might be swayed. And I would suggest that our efforts need to be focused here in the middle part. Obviously, don't spend time trying to convince people who are already planning to take it. And certainly the data shows us, the evidence and the research shows us that people who refuse all vaccines are likely not to be easily swayed toward the left of this kind of continuum. So this is our job together, not only healthcare providers, but community members, community leaders, that we need to make sure that we have our own correct facts regarding this vaccine, and that we can speak to our own trusted community. Here are some factors that influence people's generic vaccination decision. And I think that that's especially true in contextual external influences, and now here COVID vaccine specific issues, where probably the most important feature is your knowledge and your attitude. Again, not just a healthcare provider, but an ambassador for this vaccine, if we will collectively get to the kind of herd immunity that we'll need to get back to life as normal. So I'd like to take just one slide to give you some resources that are evidence-based. That is, the science speaks that this is a way to approach talking to persons who are vaccine hesitant. And maybe this is to you as well. Maybe you are vaccine hesitant. So for example, in the column on the left are the words that have been found by research to be more effective at moving people toward taking the COVID-19 vaccine. And the column on the right, the black column, is a set of words that have been found to be not helpful or even moving people further to refusing the vaccine. So this is a bit of a compare and contrast exercise, but it seems more effective to talk about the benefits of taking as opposed to the consequences of not taking the vaccine. People want to hear that getting the vaccine will keep you safe much more than they want to hear that it's the right thing to do. Vaccines will help us return to normal rather than fancier science kind of words like predictability, certainty. People also are appealed to move toward taking the vaccine when they understand it can protect their family over a community. We want to refer to the people who have been involved in the process of bringing this vaccine to us and are advising us now as medical experts. Whereas there's an understanding through research that referring to people as scientists or health experts might not be as appealing. I guess scientist has that sort of evil, sort of potentially negative connotation. We want research, not random discoveries or creations or inventions. We talk about medical researchers and not drug companies. And I think that I'll leave this for you to review. And when we share the slide deck, this will be an active link for you to get more tips if you are on those front lines of helping people come to accept this vaccine if they are now hesitant. Again, I highlight here that I understand some of you are vaccine hesitant. Some of you want your answers so that you can go safely about receiving this vaccine. I know that you're concerned about the vaccine, as many of us are, and I'd like to take on some of your questions now in the next section. I put this in quotes because I feel as though I have been saying this many times, but it still means I believe it. Safety of the COVID-19 vaccines has been, is, and will be a top priority for every agency at every level of government. It's important and I think reassuring for people to learn that in the United States, the COVID vaccine process has been held to the same safety standards of every other vaccine we've received. There have been agencies with redundancy doing analyses of all available data to bring us the recommendations that we enjoy today. So I believe, as I imagine you do too, that many people in the United States have seen the speed with which we've received these vaccines as something to create hesitancy. That is, people are concerned that vaccines have been rushed, it's gone too fast, we don't know enough. So let's talk about that. I think that understanding how these vaccines have come to us can be very empowering and provide people the courage they need to step up to vaccine. So for example, yes, they have been fast-tracked, but they're held to the same safety standards as always. Researchers used existing networks to conduct the vaccine trials. They didn't have to set it all up from start. They even began making vaccines while they were still studying them in a tremendous collective optimism that they would be successful. That means that some companies' vaccines had to be thrown away. They didn't come to fruition, but here we are now poised where we are today because Pfizer and Moderna were able to manufacture while they were completing their trials. That's unprecedented. The mRNA vaccines were chosen specifically because they're faster to make than many traditional vaccine types. So there's no sinister reason that we've gone to this new form. but they are faster to manufacture, and they're also more adaptable in case the virus changes over the next months and years. I think many of you are seeing that in headlines. So we're well positioned to change this vaccine very quickly in order to protect our populations. And then in one of the major steps that allowed us to receive this vaccine in record time, our agencies federally prioritize review. There were no delays, no hesitations, no such thing as a weekend or long hours. And I would say that's the way it should be, not only for COVID-19, but for all of our processes that bring important products for health to us. But that's what's brought us here today. So I'd like to also reframe the dialogue that we have in many of our communities around side effects. Side effects, soreness at the arm, feeling tired, having headache, maybe even a bit of fever, means the vaccine is working. It's stimulating your immune system. It's getting you ready in case you ever see this virus. So this should be a cause for being happy, not being afraid. These side effects are very well characterized because these vaccines were studied in tens of thousands of people. We know they are mostly extremely transient. They rise by the end of the first day after the shot, they peak in the second day, and they begin to go away by the third day. Some of that arm soreness may linger, just like a flu shot or a Tdap or any of the other vaccines we get. It's normal. These side effects are less common in people who are older, but we have to recognize, we have to be transparent and talk about the fact that sometimes people have side effects with the first one may mean they don't want to go back for their second shot. And I believe that would be a mistake. We want people to understand, to expect these side effects, to consider them good news, in fact, and come back for the second dose so that they have high protection that lasts a long time. Receiving the vaccines can also complicate our screening processes for the disease itself. That is, if you have a small fever or feel unwell on day 2 after vaccination, it's sometimes hard for doctors to know whether that means you actually got COVID-19 in the interim from your vaccine, unrelated to receiving the vaccine. But we're certainly asking people to still be careful. If you have symptoms, disregard vaccination status, and in most cases, go on for testing. So a lot of folks are asking, who can't get the mRNA vaccine? There's a lot of misinformation out there. Even in some of the questions that are being presented to us ahead of time, lots of rumors and talk of, I heard someone say, I can't get it because. These are very simple rules that the only people who cannot get this vaccine are those who had a severe allergic reaction to their first vaccine, or is known to have a severe allergic reaction to any ingredient in the vaccine. I see that question within the list of questions pre-positioned, and you can easily know what ingredients are in the vaccine. We've put it out through our health alert networks. It's available online. It's given to you when you register for the vaccine, and on. There's no secrets. We want everyone to know exactly what's in every shot. And they can tell whether they've ever had an allergic reaction to anything in them. Regarding how common this is, I think it's probably worth answering this question as well. Severe allergic reaction, such as anaphylaxis, is extremely rare. The current tally is only 11 times per million doses given. So this is a rate that rivals what we expect and appreciate and endure, in fact, for other vaccines. But it means if you're one of those unlucky few, you should avoid the same class of mRNA vaccines. So you can't mix and match these vaccines. That's another question that's come up in the pre-position questions. So let me take that on right there. If you start with Moderna, your second dose needs to be Moderna and vice versa. You shouldn't be getting other vaccines at the same time as receiving the COVID-19 vaccines, only because your immune system that makes your protection against this virus might be distracted. It might not give this vaccination the full attention it needs because it's responding to those other vaccines. It's not dangerous, but it just means you might not get as much protection as we want you to have. Basically, everybody else can get it. I like to say over and over again, because the question still comes, if you've had COVID-19, you should still receive the vaccine, because as we learn more, it turns out that the protection a person gets from having had disease itself is short-lived. It may last 3 months, 4 months, 5 months, but it seems to go away pretty quickly. And we're already starting to see people having second bouts with COVID-19. We only ask that you complete your isolation if you had active infection, so that you don't come sick or come contagious to other people who are getting their vaccines at the same time. If you have severe allergies to other things like animals, foods, other chemicals, it's okay to get the vaccine, but we ask that you stay for observation wherever you've gotten it for 30 minutes. This is put in place in those fixed sites. This is at your doctor's office. This is everywhere, that they are all adhering to this just to be on that safe side. You can get it if you're immunocompromised, if you've had Guillain-Barré, if you have latex or egg allergy. These are questions I get a lot. And then women who are pregnant or breastfeeding also are encouraged to get it, because we increasingly recognize that being pregnant itself is a risk factor for having a very bad outcome with this disease. You can't get COVID-19 from the vaccines. People often say that about the flu vaccines. So I'd like to take that on ahead, and I want you to be ambassadors of this information. None of the vaccines in use, or even those that are under development, use live virus. So it's impossible that the virus takes off. There's no such virus in any of these vaccines. But these side effects that might even include fever and other symptoms like COVID are often misinterpreted as COVID itself. The other thing that happens is that sometimes people were already infected with COVID-19, they didn't know it, they got their vaccine, or they got COVID immediately after getting the vaccine, and it's a coincidence. It's not that the vaccine gave them COVID-19, but it just didn't have a chance to work yet. I'd also like to be very clear that the vaccines cannot cause you to test positive. That is, if you have symptoms and your healthcare provider decides to test you, if a PCR or antigen test, which are the acute diagnosis tests out there, are positive, you have to assume then that you are one of the unfortunate persons who for whom the vaccine did not work, or you were incubating disease before it had a chance to work. So always have to interpret these tests, if they're positive after vaccination, as true positive. So now I know a lot of questions have been positioned about this, and let me see if I can take on who can get the vaccine when. First, to frame it, we are early in this part of the curve, and I know this is kind of sciencey, but it's highly intuitive, I think, to everybody here. There are simply not enough vaccines for everyone. We have had to take decisions on who should get vaccine first. And hopefully we will get to a place when there are a large number of doses available, and then getting the vaccine will be normalized. You'll get it through your doctor's office, the commercial pharmacies, as a booster as needed. I don't know. But right now we're in this awful place where we simply don't have enough vaccine to give everybody who wants it to on day one. Deciding who gets it in these early days and weeks has been a long, careful process. In fact, it started decades ago, because a core public health function is to decide who gets limited resources, such as in pandemic influenza. So we've been planning for this for a very long time and had some draft plans in place. It's had to be changed according to what we've learned about COVID-19. And the process for changing the draft plans has been driven by a very dedicated, multidisciplinary branch within your health department structure, where we meet hours every week and have done so for the last months in order to provide as much detail that is evidence-based, that is science-based as possible. The process has also been supported by an outside group of experts called the State Disaster Medical Advisory Committee. This is a governor-appointed committee who has reviewed our plans along the way. And then ultimately, the decision is taken by senior leadership in the state, such as the commissioner and governor. This is the current allocation plan summary. And I think many of you probably have gone online to see this already. The link is there, but it is in phase 1, 2, and 3. Each phase has an A and a B, and the approximate population number is shown for each. So of course, you all know, we have essentially completed phase 1A, and now let's talk in more detail about phase 1B. This is anticipated to take through March, but that is dependent on whether we can get additional supply of vaccine, which is possible. And it also depends on how many people are vaccine hesitant. I certainly hope it's the former reason we move through faster than the latter, but it's possible that not 100% of people in phase 1B will step up to taking that vaccine. So let's first say that there are now some pretty public-friendly tools available to help you know when you can get the vaccine. So it's described in this graphic, and it's also available online, either on your cell phone, or you can look on your computer, or somebody can help you work through it, whether you're in phase 1A, B, or down the line. So let's talk 1B. It's a huge day for the state of New Hampshire today. Registration for phase 1B started. And from what I heard at last report, we were registering 1,000 people a minute to receive their vaccine. So it's likely slowing down over the course of the day, but it's been a tremendous success for us to see how many people are interested in this vaccine, and allow them to then choose where and when they receive it. The 5 different populations who are in phase 1B are those who are 65 and older, those who are medically vulnerable. I'd like to talk more about that population because I think it's represented by the people who are on this call. Also, residents and staff of residential facilities for persons with intellectual and developmental disabilities has been called out as an important population for vaccination. Corrections officers and staff working at correctional facilities, and health workers and first responders like firemen, police, EMS, who have not already been vaccinated. I draw your attention also to this underpinning, which begins in this phase and continues through the rest of New Hampshire's use of our 17,000 doses each week. We will allocate 10% for disproportionately impacted populations based on a federal and state nuanced vulnerability index. That is, there has been intense scrutiny about which populations, which areas, which geographies are most vulnerable to COVID-19 in our own jurisdiction, in our own state. And we will try to reach them through a parallel mechanism over and above what you see in the pillars as shown. So coming back to medically vulnerable, this is a large group, but it's also a very diverse group. There's lots of different kinds of medical vulnerabilities, aren't there? So we've tried to define that in what we refer to as technical assistance. So these documents are online for clinicians and for you to review to see if you are a person at significantly higher risk of getting sick or dying with COVID-19 by virtue of having 2 or more conditions that we have laid out in detail. Note also that the governor wants to provide family caregivers of those persons who are medically vulnerable, who are less than 16 years old because they are not eligible for vaccination. Every word is chosen carefully and has been the intention of state leadership. So I do see many questions about whether it can be non-family, whether it can be persons who are older than 16 and the like, but it is written intentionally, and I do not have the ability to make changes in it myself, but we will talk more about that, I believe. I'd like also to make sure that you understand, again, that these morbidity and mortality features, the medical comorbidities, the reasons that people don't do well are pretty clearly delineated within our technical assistance. And it's described in detail according to these bullets. These are practical suggestions, but not requirements for clinicians to identify patients who they believe are at increased risk of severe COVID. And I want you to know a few things about this. They are not required to use this. They are encouraged to use this because this is what the science has shown us over the 1 year of this global pandemic. That is, people who have current cancer, people who have compromised kidney function, and some of the medical terms here are shown, those who have so-called chronic obstructive lung disease, but also other high-risk pulmonary diseases that actively are compromising their lung function. Within each of these kinds of categories are also statements regarding who not to consider in these groups to try to help doctors and nurses, nurse practitioners and PAs to sort through this before they attest on behalf of their patients. That is, before they put forward the patients they think are at the highest risk for severe disease. This is the second page, and I know that this section will be of interest. Down syndrome is specifically called out by research as one where persons are at higher risk of morbidity and mortality. But we also recognize that there's a lot of spectrum with regards to disability from this disease and other chromosomal abnormalities that were not common enough for us to have the evidence we need. That is, some of these populations are simply not big enough to tell us with confidence that they are at higher risk or not. So we've made some suggestions here, such as limited data regarding other kinds of chromosomal abnormalities, anoxic birth injury, or severe autism spectrum disorder. So we suggest including such patients if they are severely impacted in the ways as described, with some particular, I think, an important statement that the autism spectrum disorder is, in fact, a large and diverse group of patients, most of whom are not thought to be at increased risk from COVID-19. So again, we continue to check in with the science and the data, and this is the suggestions that have emerged and been agreed to within our own state. Heart conditions and other cardiovascular and cerebrovascular disease is described here, and also those with immunocompromised states, essentially limited to solid organ or bone marrow transplant patients, primary immunodeficiency, or advanced HIV/AIDS. If you want to see these resources, please do attend our website, go take a look, or have someone help you do so. I think the button of most interest today is this very one here. This is how you get to vaccine registration by virtue of age, and your doctor will attest, and you'll be able to register through these mechanisms. I know there are many other questions that I didn't have a chance to answer, but I'm going to end didactic here with, again, a very sincere thank you for attending and participating in this session today. I hope that we'll have time to answer your specific questions.
Thanks, Dr. Talbot. And I know we do have a lot of questions coming up through the chat, so I'm going to just try to pull that up. And I wonder if you could speak to a couple of things. One is, I think there was, and this is sort of a vaccine rollout question, right? I think there's been some confusion that folks have had in terms of whether they're going to their doctors or they're working with their area agency and the regional public health network in terms of getting registered. And I don't know if you or Dr. Ballard could speak to that process a little bit.
Sure, I'm happy to help. And again, express my gratitude to the area agencies and all the persons participating today. We try to make it as straightforward as we possibly can, and we've been communicating with all of the health practitioners across the state in a variety of formats, including those health alert network messages to all the providers, and trying to communicate through the governor's press conferences, as well as formats like this and through the associations that serve clients that may fit within these early categories of persons eligible for vaccine. So for those persons 65 and older, there is a website where persons can go to get vaccinated and register today. And that's that website that Dr. Talbot shared, vaccines.nh.gov. For persons who do not clearly meet a definition that's as easily clear-cut as whether you're 65 and older, we're working with our healthcare partners. We have created a secure way for any healthcare practitioner across the state to upload the patient's information to us at the Division of Public Health Services so that we can get you registered and reach back out to you. Either if you have email, we would send an invite letting you know that you will be invited to be registered for a vaccination appointment as part of phase 1B. So that would include all those persons with 2 or more health conditions as listed there and from the science shared with us from the Centers for Disease Control and Prevention, as well as those persons who their doctor attests to them having significant risk of disease that would cause complications if they were to contract COVID-19. The other groups as well, there may be persons with intellectual or developmental disabilities who live in a group home or congregate setting, and that those organizations are encouraged to work with entities known as regional public health networks to determine whether it's better for vaccines to be brought and delivered on site versus potentially in some settings and smaller settings, it may be better for persons to go to one of the state-run vaccination sites across the state. So we try to make it as straightforward. 65 and up, go to the website. If you're in a younger population, speak with your doctor, and your doctor can easily upload and send us that information of who we should reach out to. We'd certainly, if they don't have an email address, we would reach out otherwise through telephone over time.
Great, thank you. Okay, I've seen a number of questions that I'm going to try to sort of paraphrase, if you will, about sort of the decision-making process for folks about the vaccine. There's, obviously, I think the CDC, our own public health is very, very much trying to inform and educate the public about the benefits of the vaccine. And, if we could kind of come back to that question about vaccine hesitancy, I know there's, again, just looking through the chat, I see a lot of questions about that. And I wonder if we could sort of revisit it from the standpoint of, what's the best, how would you advise somebody who still is on the fence, I guess, about whether or not the vaccine is for them or their family member, particularly if the family member has, any number of metabolic or chromosomal conditions that where there's no data to support the safety or efficacy.
One thing that I've been very happy to see is that the vaccine researchers did try to enrich their study populations for persons who do have other kinds of illnesses. They didn't just look for the healthiest people in our society to bring into the trial, but went out of their way to look for older persons and persons with autoimmune disease and other kinds of illnesses. I have found repeating the true phrase that safety has been the top priority for developing these vaccines, and making sure that I keep myself aware of any new information, like the rate of anaphylaxis that I showed you. I think it can be immensely helpful. We know that people who are vaccine hesitant can be moved toward taking the vaccine when they have the facts they need. So your job is to figure out what's holding them back and seeing if you can find those answers for them. And especially if you're already a trusted friend, a trusted family member, that's going to work well.
Thank you. I've seen a few questions about sort of the types of settings that people are receiving their services in. And I just sort of want to preface this by saying, you know, there's a number of different phrases that we use to describe the settings that people are living in and receiving supports in. Can we speak a little bit more specifically about the facilities, IDD facilities, and what, you know, what we mean by that, how people access that information?
You're right that there is some confusion, even on my part, regarding the many different ways that people access services, whether it's in residence or through day programs, and when they're supported by family members or professionals. So my understanding, what I keep coming back to, is that within this state of New Hampshire, the priority is vaccinating first the people who are most likely to be hospitalized and die from this disease. There's also an obvious need to make sure that there are enough health workers to take care of those people when they're sick. So those are the two criteria that our state government has offered us as number one priority. So again, that's why it's so important for us to keep going back to the science, look back at the evidence, look back at our numbers in our own state to figure out who are the vulnerable people. So a very dynamic process. But right now, as you know, you can access vaccine by being a health worker. That doesn't mean you need an MD after your name or an RN after your name. It means that you need to understand that if you're in a professional role where you're doing clinical care of a person, you can check out our phase 1A technical assistance and find yourself there. So you would be prioritized on that basis. You now, as of today, also can register if you are 65 or older. So that's another way to get your vaccine now. The third way that's likely relevant within this group is that if you have your own medical vulnerability, as I've described in probably more detail than you wanted, you know, sort of like what are the clinical conditions that would bring you to getting this vaccine, that's another way. As said, we have specifically delineated, called out, and described that residents and staff, whether full-time, part-time, paid or unpaid, of residential facilities for those with intellectual and developmental disabilities are now open, invited, encouraged to access vaccine. So I know in the pre-submitted questions, there are many around, well, what if I'm not one of those people? And many people are making very clear cases, you know, making very passionate, informed arguments to include persons who, for example, live independently but have medical comorbidities. So perhaps it's the medical comorbidity that brings you to vaccination. This is at the discretion of your doctor, your PA, your NP, your healthcare provider. Because people who are younger than 16 can't receive either of the currently available vaccines, we hope it comes soon, but right now, because they can't, we want to protect the family caregivers around those people who are medically vulnerable. So there's lots of different ways to check this box, but it's not by going to a day program or going in an independent apartment if you don't have some of the medical comorbidities. And I tell you, honestly, I get it. I think, you know, it's hard. We wish we had enough vaccine for absolutely everybody right now, and we simply don't. And these are the decisions that have been made through I think, a careful, long process of experts, internal and external to the state. And I know that there are people who are unhappy with these decisions. So I'm just giving you a nod that please be patient. There is also the underpin of equity. So some people will also be able to access vaccination through the equity allocation that I told you about. That is people who are disproportionately impacted by virtue of racial or ethnic minority, and also sometimes poverty, homelessness, or other kinds of
Albert,
issues.
if I could just clarify some of that a little bit, and I think it might help to ask some of the questions that are going in through the chat. So I think the biggest question for families that have children over 16 are, they are providing that level of care that those healthcare workers and direct care workers who are in 1A and 1B are already providing, but they're just doing it unpaid. And many of them are doing it because they don't have the workforce because of the workforce challenges that COVID has brought. And so I think the frustration is that even though that individual over 16 does have the opportunity to be vaccinated, if the parent caregiver of that child gets sick from people that are, still coming into the home, or if they're still working themselves, some of our families, their children that are above 16 still require total one-to-one support. They require intensive nursing support. And so if those families get sick, there's nobody to care for those individuals. And I think the question has been, where do those people fit in? Because those individuals would technically be living in the long-term care facilities that are in part 1A and 1B, and those families would be the paid staff, but they're just doing it unpaid at this time. And so I think that that's a question, because for all purposes, you're providing the same level of care for those that are already being vaccinated, but there's no way for them to check the right box to get fit into that.
Thank you so much for bringing that question forward. We're hearing that from a variety of persons. And in an ideal world, when we weren't in such a scarce resource setting of a limited doses of vaccine, we would want to vaccinate absolutely everyone that would be willing to accept it. And these have been very difficult and tough questions to answer about when we're in such restricted amounts of vaccine that is available, of which persons should have the opportunity to receive it first. And so the framework for the state has been to prioritize the individual themselves who would die or have a significant complication such as hospitalization if they were not to receive this vaccine. The allocation is not based on preventing the contracting of the illness at this early stage. It's focused on the individual, protecting them from being hospitalized or dying. So those that are at greatest risk are those persons that are, from the sciences informed, as those that Dr. Talbot mentioned, as well as those individuals who are less than 16 years of age, who cannot get vaccinated because there's not an FDA approval of the vaccines. The Pfizer vaccine is approved for those 16 and up, Moderna for 18 and up. So those individuals that are, although extremely, absolutely essential, important for caregiving of those others, so far are not being prioritized over those who would be at increased risk of dying if they were not receiving the vaccine at this point in time.
Okay, at the risk of being shut off this call completely, which will not be the first time in my life, I'm going to advocate for one thing, and that is that as a caregiver running a PDMS family-run program for my daughter who is medically compromised and would be able to get the vaccine, but as her caregiver, if I get sick and I'm no longer able to care for her, where are you going to place her when I am not here to medically take care of her? Who is going to replace me? You're going to have to hospitalize her in order to keep her safe while I recover, if I recover. That is going to put One Sky alone has over 100 families in this position. If you have to hospitalize and take care of 100 developmentally disabled people, your hospital system is going to be so overrun. Plus, your hospital system isn't even ready to even care for these people, which is why they're in home-based programs in the first place. So saying that they are not, I like the way that Elizabeth had said, Ms. Talbot, that unpaid caregivers technically should be a part of this. We are unpaid caregivers, but we are doing the same work and the same as if we had paid staff coming into our homes. In fact, I have both. I have paid staff who are getting the vaccine versus myself as a caregiver who has to do certain hours a week within this program. I'm not eligible for it. That is wrong because I'm the one that runs the program. If I'm not here, her staff doesn't even show up. There's a big forgotten entity here, and we're a small entity compared with all the other ones out there that you have to consider. But I'm asking you to really think long and hard about the difference between paid and unpaid caregivers for the compromised people with DD. Really, it's a really big problem if we start falling, what you're going to do with all these individuals. Thank you. I'm sorry for interrupting, but I'm sorry, I'm passionate about this one. I'll go all the way. So there you go.
Thank you so much for sharing that. And again, this is a resource and opportunity for us to hear feedback as well. And it's extremely gratifying to hear this feedback. For health workers, again, it doesn't matter if it's paid status, unpaid status. For health workers, it's about function, providing health-related services to individuals. So again, it does not matter about status, about paid or unpaid. For family caregivers, again, if someone is under 16 and unable to receive the vaccine themselves, they can have that attestation done from the provider. We have a mechanism that all providers have had it shared with them, that they can attest that the family caregiver of a person under 16 that cannot get vaccinated, who is at significant increased risk of bad outcomes such as dying, can get vaccinated as well. For those persons over 16, we want to protect the individual in this framework as it stands now to become vaccinated themselves. And so it's in an ideal world, we would absolutely want the vaccine to go to other persons who are not at increased risk of dying or having a poor outcome. We've tried to use science to inform as much as we can, medical evidence to inform as much as we can, that the groupings that are in this phase 1B. We believe that it covers over 95% of persons based on our year experience of data, that if one were to contract COVID-19, we believe that over 95% of the people in this phase 1B will be included in this vaccination phase.
So are you saying that if you consider yourself a healthcare provider, the same as, for example, DSPs were providing care and are eligible for the vaccine because they go into other people's homes and provide one-to-one care. If the parent is also, or parent or family giver is also providing that one-to-one care, the same as a DSP, are we saying that they are an unpaid healthcare provider? Is that what we're saying?
Dr. Talbot, I believe that we put some guidance out about what a health worker is. Can you share a little bit about that?
Well, as said, we have, I think that is a very practical guidance online. It's called the Phase 1A Technical Assistance. So please take a look, because if you are doing medical procedures, paid or unpaid, if you have a title, I remember using the phrase before, even if you don't have an RN or an MD after your name, that's a health worker. So I think that can be helpful to some people who feel as though they've been forgotten, because that's certainly intending to cover just what you're describing.
Right, and I think that's what it did happen, is we do feel forgotten, that we've been overlooked as a segue. And in 1A, we kind of stood back and said, okay, well, we're not technically paid because it asked for verification of employment, right, as a way to verify that you should be in 1A. So we kind of stood back as parents and caregivers and said, all right, well, we'll see what happens in the next phase. But when we weren't specifically mentioned in this next phase, now is the time of, whoa, wait a second, we're not being slotted in where we should be anymore. Does that make sense? So I mean, I would really love to have some statement from the health department addressing this significant piece that unpaid healthcare providers, be they family members or not, be included in, I mean, at this point, 1A is almost mute, right? But at least in 1B, so that we know that, you know, people are hesitant. They don't want to do the wrong thing. They don't want to rush and put themselves ahead of everybody else. But what is the process for unpaid caregivers, healthcare providers of their loved ones in their home? What is their process of getting verified to get this vaccine?
Thank you so much. We
Okay.
use the word health worker intentionally. It's not health care worker. We use the word health worker for this very purpose.
Well, I think as parents who really feel like we don't want to rush in and take the vaccine from someone who needs it, you know, we didn't want to view ourselves as health workers, even though we know we are, but, you know, we wanted to give the chance to, you know, for that to happen. So out of respect we have, but now we need to get that addressed.
There's been another process question that has come in, actually many of them that maybe would be helpful to take back and figure out the piece of it. But for those that have children or adults that fit underneath the medical fragile and need to get the two, that kind of qualify under the two or more distinctions that the state has done, what's happening is people are going and registering on the website, and then once they get to the end and it's clarifying, yes, you qualify, it's kicking them, it's giving them a message to go back to their doctors for the documentation. The challenge with that is for others that are over 65, they don't need that qualification, so they're able to kind of pick their slots at that point where the individuals that have medical challenges are having to wait this time frame to then go back and get the documentation before they can do that. And with such limited amounts of vaccinations coming in, the challenge is that those people are waiting even longer now for an appointment because of that additional step. And I think there's been a lot of questions that have come in of how can we, how can that part be addressed? Because it's kind of marginalizing our community even further away from being kind of next in line for that.
Heather, again, thank you for this, bringing forward this question as well. And so I would hope to bring some clarity to this. So for those persons 65 and older, as well as those residents and staff members at a facility for persons with intellectual or developmental disabilities, they can go to the website today and register. And when I say register, it means become part of the cohort, the group of people in phase 1B that will eventually get an invitation to schedule an appointment. So the same groupings of persons, if we're also receiving listings of persons from doctors, PAs, nurse practitioners from across the state who fit in the category that you described. We're also getting those right now as well, and many of them. And so it's not as if there's going to be a group one over another. I mean, ultimately, at some point in time, we have to send out the invitations, and those invitations are going out now. But just because that grouping is coming to us from your provider, it doesn't mean that someone else who registers online after your provider has sent us their attestation would be ahead of the line, for example, for them. So they will all be into the grouping for phase 1B, and they will all be sent invitations to schedule appointments. Again, we're in such a very limited resource setting, and so a message is patience. All of these groups, based on the science and what the information we're getting from the CDC, are all important, and they all should be vaccinated. And so that's sort of where we're at in the messaging and where our goals are to encourage and hopefully people will be vaccinated as part of this group.
So Dr. Ballard, I know we're actually a couple of minutes over 1 o'clock, and Dr. Talbot, I think obviously there's a lot of still a lot of questions remain for folks, and I just want to give you an opportunity to sort of share how people can get their questions in to DHHS for further follow-up. I think we're very, very grateful for your time today. And I know that, again, there's probably, with every presentation you do, there's, a lot more questions that come to you from that. But I want to make sure that people have the address for sending additional questions in.
Well, one thing I might offer too is that we have a follow-up call, but it's true, I had a 1 o'clock meeting to start where we have the persons who are most up to date on the operations. Like I see a lot of questions around registration, calling 211, et cetera. And I happen to not be the person who represents the day-to-day operations of accessing. And I think it's so dynamic that, in fact, maybe we could devote some time to that together so that people have full understanding. The intention here in this last hour was largely to make sure you had your vaccine science questions answered and you understood the intentions of the plan, if not the deep details of operations. So is that, do you think, something that would be helpful for persons?
I think that would be greatly appreciated. Absolutely.
And we're happy to come back, and this is a continual effort, and
I have one question that needs to be answered is what about out-of-state PCPs? You're talking about people who live on border towns and sometimes go out of state for that. So that has not been addressed. And I would like, if there's a form that be a little bit more accessible to us to take to them and get filled out.
great. So I think someone just put the form online there, but it's about the resident of New Hampshire. And so an out-of-state PCP is okay to send a registration attestation that their patient who is a resident of New Hampshire can be vaccinated. So there's a form there. It's also on our website. If you go, for easy sake, if you Google New Hampshire and COVID vaccine, you will come straight to our website, and those forms are available there.
And with that, I'm afraid I have to sign off. Let's consider this the first conversation, and we'll come back together, especially as we'll bring back the operations experts too. Okay, so with that, I'll say goodbye and stay safe.
So
Thank you very much for your time.
Thank you.
Thank you. So Jonathan, I will work with you
Sorry.
and the CS&I team to do a follow more operational call. And I know that the chat box has captured a lot of the implementation questions that have come up.
Mm-hmm.
And I'd like to thank families for their continued patience as we work this through. And to please reach out to your local area agency with questions, because an awful lot of information is being pushed through to them. And a lot of the links and information that have been put up on the chat box today are available through your local area agencies. So thank you again.
Thank you. And Dr. Ballard, we'll send along through Deb to the additional questions that have come in as overflow that we've been collecting. So we can just make sure that you're.
I also put it in the email address in there. We have an email address that persons can get answers from. It's covidvaccine@dhhs.nh.gov, as well as they can always call 211. And we do, 211 is also the number right now for registering, but we still have persons available to answer COVID vaccine questions as well as registration. If you don't have access to the internet, or if there's a challenge for that for an individual, they can also call 211 to become registered if they are in that group that's over 65 or the other category of a resident or a staff member at a facility. So otherwise, we also have that information that we're sending out to providers. They have all the tools that they need to be able to submit for vaccine requests to the department, and we will follow up with all those requests as soon as we can, given the scarce resource of the vaccine. And we did, again, thank you for everything you do. We ask for your patience. This is a trying time for everyone, and we recognize all the work that you do for your loved ones and for the whole overall society. Thank you.
Thank you very much, Dr. Ballard. All right. Thank you all for attending today. I know we didn't get a chance to get to everybody's questions. This is the first and hopefully a series of information sessions and Q&A that we can facilitate. And again, thank you for hanging in there with it.